So when you tell a patient what to do and you don't help them understand why to do it and what the purpose is and how to do it, they don't necessarily listen. The number of times that I've tried to get a large healthcare organization to incorporate health literacy, and they've told me that they already have, and they pay hundreds of thousands of dollars, millions of dollars for the systems that they help us, log on and pay and, send to us all the health education materials that are terrible.
Catina, thank you so much for hopping on our podcast. Excited to speak to you today, learn a little bit about your background, your work at Health Literacy Media. I know healthcare, patient education space and communication space is something, many organizations need. And so I know you bring a wealth of knowledge and perspective on this topic. And first, just wanted to learn a little bit about what led you to start Health Literacy Media, and what need did you see in the way clinical and public health communication was being handled?
Well, thanks for asking. I joined Health Literacy Media about 13 years ago, and it was a young organization, a young nonprofit. So I joined after Health Literacy Media had been started about 3 years prior. At that point, it was called Health Literacy Missouri, and it had been started by a group of folks here in Missouri based on a project by the Missouri Foundation for Health. So the Missouri Foundation for Health is a conversion foundation that had focus on helping Missourians understand health information. And they came together and they thought, what better way to help people understand health information than to put together a nonprofit focused on helping folks do so. So they created Health Literacy Missouri, and our job really was to do that work. At that point, the folks that were leaders in Health Literacy Missouri hired some journalists, and they hired writers. And they started to teach people how to understand medical information. They placed stories in newspapers all over the state. They wrote materials to help people in doctors' offices. They went out and they helped hospitals and clinics, and people learned to ask questions of doctors and understand how to get around in medical systems. And they really just helped people start to learn to ask questions and use the medical system better and feel comfortable in that space. And it was really a movement then. There was a Surgeon General's report about that time called the Prescription to End Confusion, a Prescription to End Confusion. And that really was important. It was the beginning of thinking about how communication could help people understand healthcare. People started to talk about plain language. So there were some really important legislation at that point to talk about plain language writing. How do we get rid of jargon in medical writing? People started to think about prescription labels and how they needed to be more clear. You see things like on a prescription bottle that says, take these 2 pills 2x/day.
Yeah.
Well, you don't think about that because you're used to seeing it, but it's a complex algebraic equation, right? 2x by day is algebra. You may know that because you're a person that's probably been through college and has had lots of math, but for folks who have not had maybe as much math or not had math in a long time, they may not understand that means you take 24 hours in the day and you divide that by 2, which means every 12 hours you're supposed to take 2 pills. So that doesn't mean just take it 2 times. It means you take it once at perhaps 8 o'clock in the morning when you get up, and then 12 hours later you take the medicine again. If it's 3 times, you take it every 8 hours. So you actually have to divide the 24 hours by the number of times per day. Everybody doesn't know that, right? So you've seen since that 2009 report and these conversations that people have about health literacy, prescription labels have changed where they've gone from those words only. You'll see that there are pictures on a prescription bottle and they show you morning, noon, and night, for example, instead of just the algebraic equation. So all of this was happening around 2009 or so, and companies like Health Literacy Media were starting to develop. There are a set of those around the country. Some of them are for-profit. Some of them are universities that have health literacy departments or writing departments. There are some literacy organizations who also are focused on helping people in communities learn to read. And so all of these companies are sort of thinking together. So Health Literacy Missouri was here in Missouri, focused on that work. We got some contracts with folks in Pharma over the years, early on about 2012 when I joined. And those folks in Big Pharma said to us, it's really great that you're doing this work. We want to help you continue the work you're writing, helping us learn about health literacy. It's very hard to explain why we would work with a company called Health Literacy Media when we sit in, say, New Jersey or Connecticut or somewhere like that. Help us understand that. At that point, we thought, well, geez, Health Literacy Missouri probably is pretty localized and pretty specialized.
Yeah.
So we already called ourselves HLM. So we became Health Literacy Media as well as Health Literacy Missouri. So depending on where we're doing business, we're one of those two things. But that's who we are and how we became. And we're
Yeah.
just one of a group of folks who are doing this work. We just happen to be the nonprofit source that sits in Missouri and does the work here and around the world.
Yeah. That's a fascinating background. I appreciate that. I mean, it's from the early days of Health Literacy Missouri, and it's now expanded to be Health Literacy Media. I mean, I love the examples you gave of how it started with a lot of teaching people and like how to understand like medical information. You said it was like in newspapers, doctors' offices. You gave the example of the labels on prescription bottles, and ultimately doing some work with pharma. So you've in that spanned a lot of healthcare and life sciences. What are some of like the biggest like challenges that you're like seeing today nowadays in patient education in this space? And like, how does your team like approach bridging those challenges for
Sure.
companies?
So there are a couple of challenges. One challenge has been constant, and it's that everybody thinks they communicate well. So it's really hard to convince people that they actually are as clear as they think they are. And providers, doctors in particular, don't get a lot of training in medical school about how to communicate. They typically are folks who are brilliant. They learn how to diagnose and treat, but they don't necessarily learn how to educate people about what they're doing. And we know that many adults don't do well at being told what to do. So when you tell a patient what to do and you don't help them understand why to do it and what the purpose is and how to do it, they don't necessarily listen. So that communication gap between a provider and a patient is pretty big. And very frequently, providers don't think that they need training on communication. So that's a constant challenge, is helping doctors and other healthcare providers understand that there's a reason for them to learn to communicate. There's the reality that they have to learn so many other things that are really important. The communication piece doesn't seem like it's that big of a deal. The reality is, if patients don't want to listen, if they don't hear you and understand and care about what you say because they think that you're a jerk or they don't understand or they're embarrassed or whatever reason, it doesn't matter how smart you are, or it doesn't matter how important the information is, it's still lost on them. So that's challenge number one that has been ever present. The newer challenge to us in health communication, health education, health literacy really is the challenge that we're experiencing from AI. Everybody and their brother is telling us now that we don't need to provide health education because people can go on the internet and look things up. ChatGPT can write health education. Any source of AI can do this for us. And what we know in work with real writers, health education folks, is that's just simply not the case. The computers don't have human empathy. They don't understand the complexity of much of the health education materials that we have. They haven't frequently included more of the complex community members in many of the data sets that are used to train the algorithms, the data sets. And so, they're coming together with sources that don't really reflect communities and populations. And so the information that is fed back out to communities isn't as accurate as the information that comes from companies like ours with real writers and people that has been audience tested with the intended audiences. And so it's just a different source. But folks think that AI is the answer to everything. They think it's cheaper. They think it's faster. They think it's more efficient. And so we're spending a lot of time trying to help people understand why maybe we're moving too fast toward computerized solutions, and it's perhaps dangerous, particularly for patients and frankly, the most vulnerable patients, folks who are already experiencing a gap between understanding what their providers say or maybe what their opportunities are. Maybe they're already underinsured or under-resourced, and those folks are already in a vulnerable situation, and this further challenges them.
Yeah. And I mean, you were talking about the like challenge number one being like everyone thinks they communicate well, and there's this communication gap between provider and patient. I would say like the patient sometimes represent like entire populations of patients, right? Like if you take like certain providers that treat patients with kidney disease, like there's multiple types of kidney disease, and then there's communication gaps amongst that, like in their populations of patients. They may see hundreds of these type of patients, right? And then with AI, I couldn't agree more. Like it still lacks the human empathy part of like, yeah, you can get AI to write you patient education content, but is it gonna like actually resonate with your population?
Absolutely.
It's
You have
like,
to test everything. And so many times you think that what you've written is so clear and so actionable. And when you actually talk to a person, they tell you that it makes no sense. It doesn't reflect their experience. It doesn't reflect their community. It doesn't provide meaning to them. It's not actionable in any way. And then there's also the reality that so much misinformation exists in the particular climate right now that, the computers are dealing with that. They're constantly churning out information that is not accurate, and that feeds into the models, and we sort of churn that back through. And that's a dangerous source in and of itself, and particularly thinking about vaccinations and, so many of the other health conditions and challenges that we're experiencing now that are political in nature that I don't want to spend a lot of time on. But just thinking about what we know about that, if the
right.
machines are using all that rhetoric and they're filtering through and sort of building and using that and then spitting it back out to patients who are already concerned and using those sort of lenses that are based on sort of misconceptions and misinformation, we build up misinformation that makes people less and less healthy unintentionally, perhaps. Right. We
Yeah.
want to build up based on truth and accurate health information rather than misinformation that's built into systems inappropriately.
Yeah. Yeah. Right on. And I want to touch on something you said earlier on, like, on this point of misinformation. You said that a lot of this information is audience tested, if I heard that right.
It's not the misinformation, but the information. So for us, when we create a health material, we go back to the intended audience and we share the material with them and we say, how do you experience this? And we ask them what their experience is and how they interpret it. And if there's something that they interpret differently than we intended, we ask them what would make it more clear. And if it's a long material, we ask them what parts of the material are the most challenging, what parts of the material are really easy to understand. We frequently ask people to look at charts and graphics and images, and we ask them to help us understand what images make the most sense to them and what charts and graphics are most easy to understand. A great example is we do a lot of clinical trial materials where we talk about the results of clinical trials. And for a long time, we tested graphics about how we talk about percentages and things like that. And we
Yeah.
found out through those focus groups that the graphic that people understood the best was a battery life graphic. And it's because people are all walking around with a cell phone and they know when their battery life is out on their cell phone. So that is the best way for people to understand percentages now. They know when they have 20% battery life on their cell phone or 50% or 70% or whatever that is. So folks who've never understood percentages before now understand them because they all care about having their phone all the time, right?
Yeah.
I can't explain percentages in any other way more clearly, but we know that from audience testing. Would we have known that any other way? I don't know. We learned it through asking folks, and they told us that they prefer that to like a pie chart or any other graphic that we've shared with them. So
Right
we do
on.
that all the time. We ask people, we show them pictures. So we'll get a stock image. We'll take a picture from real life folks. We'll show an animated video. We'll ask them all of these questions. Which image do you prefer? And we talk through which image they prefer and why. Very frequently, if we show a video, we'll ask people, do you prefer live action or animation? And people will say, always live action. They always want to see a real person. But when we show a real person, they'll say, oh, well, not that real person. That person doesn't look like me.
Yeah.
Well, I can't get a real person that looks like everybody. Well, if it doesn't look like me or it doesn't look like somebody from my community, I don't like it. It's distracting. Well, how many characters do I have to make it not distracting to somebody from your community? I can't do that. I can't afford that. So I can build an animated video for a third the cost and have characters that are much more neutral and are not distracting. So when we start to talk about that, they say, oh, well, I would prefer a real person if it looks like me. But if it's not going to look like me and sound like me, then I prefer that animated version that doesn't look like anybody and doesn't bother me.
Yeah.
Right. So those choices of, either or based on what the possibilities are and the cost, then this is better. So those are the things that we do with audience testing that we couldn't do any other way. And you can't do that with a computer,
Mhm.
AI. AI gives you what it gives you.
Yeah.
And it's terrible, terrible, terrible with images. The images that it gives you are not even close to the ones that we get with artists and audience testing and the things that we get with graphic designers.
Yeah, that's something that like AI just can't replace. Like audience testing, you can ask it like, "Hey, what is this like market? What pain points problems does this market have or target audience?" But to get specific feedback from actual humans that are presented information, like we're far away from, I think, AI being able to do that.
Well, yeah, and it will tell you something So if you ask what an audience would say, it'll tell you something,
Yeah.
but it doesn't necessarily tell you what that audience would say. It tells you what it thinks that audience would say
Right.
based on whatever hallucination, whatever generated. But that doesn't necessarily reflect what 10 people from that audience would really say. And that's what I know. I know that when I went out and I grabbed 10 people that have never been asked before, they don't know each other, and I put them in a room or on Zoom or whatever, and asked these people that I don't know who are in the intended audience, what do they think? What does this mean to them?
Right.
I can tell you this is their real experience. They didn't know me. And I tell them, I didn't make this. It's nothing to me. You're not going to hurt my feelings. What do you hate? Make it better for people like you. Tell me what you hate about it. Hurt my feelings.
Yeah.
Go for it.
That's
And
the
they
best.
will all
Yeah.
day, every day. Right?
Yeah. That's when they tell you the live action person doesn't look like me or sound like me.
That's right.
Yeah. No, really, that's really fascinating. And you sort of started to touch on this on like sort of like the differences between like, or why live action versus animated, and you clearly, based on what you said so far, shared so far, have worked across different sectors, like pharma, clinical trials, providers, community-based organizations. Like, how do you sort of adapt the messaging to meet each audience, like where they are, right? Because there's clearly different mediums, there's different formats. How do you go about adapting that message based on the audience?
The story of health literacy, right? At the core of everything, we're talking about audience and purpose. And so that's the question always at the beginning is who's the intended audience and what's the purpose of the material? And for us, we're always looking at being as clear as possible with a core audience of people who are trying to understand health information. And very frequently, those are people who are getting new information about their health for the first time. And it doesn't matter who you are and how educated you are or aren't. When you're learning something about your health and having to make a complex decision, it's confusing and it's scary. So we don't really need to adjust the information that much. We just need to make sure that it is respectful and that if there's a decision point that requires real thinking and there are, graphics or animations or language that it reflects who you are in a respectful way and you can see yourself in it. So that may mean that there are multiple versions or something like that. But beyond that, it really is just knowing who each material is for. And that's what we say to all the audiences, whether we're working with academic partners or government or pharma or hospitals and clinics. It really is, who do you work for and what's the purpose of the communication? And let's go back to who those folks are. What do they already know? What do they need to know? What are we trying to communicate? And that's one of the big shifts, I think, too, that we have to help people understand is, people do always assume that patients are less experienced than providers and, that they need to go back to the drawing board. And that's another thing we've learned with audience testing is that frequently patients and caregivers who have lived with health conditions are experts and they know more than healthcare providers a lot about what they've experienced and they have a very different view. And so that's one of the other tricks is just thinking about, again, in a certain audience, always thinking about what they already know and what they need to know. And sometimes what they already know is a lot. So, making sure that we're really respectful always of what the audience already knows and how do we join them as partners rather than speak down to them and sort of meet them in a place where they've already passed us.
Yeah. Yeah. No, I mean, spot on. I mean, clearly like different formats of videos are effective for different audiences and formats, and it's probably not a one size fits all model as a clinical trial versus like community-based organizations or providers like, that are working at hospitals or provider groups, right? These concepts, I would say plural of like patient education, like health literacy, like communication. How do you get like these different organizations to understand the value or the importance of it, right? Because there's like you and I both understand or like probably agree that it's important, it's needed. I would venture to say there's a lot of organizations out there that like there's a disconnect in the value that they associate with it. Like they know they need it, but like do they prioritize it in the organization?
Right.
Not as much as they should, right? So like, how do you get them to turn the corner with that? Is there like specific data that you guys have collected that you're able to present to them? Are there stories? I think stories always, tell even a bigger picture than just data. But yeah, fill me in on that and how you
Right.
get organizations to turn the corner with that.
We don't always get everybody there. That's the first thing, is there are a lot of organizations that just are not ever going to get to the value first. One of the hardest organizations for us to get to the value is frankly large healthcare organizations. The number of times that I've tried to get a large healthcare organization to incorporate health literacy. And they've told me that they already have a patient engagement group, or they already have this internal, and, they invite me to join the forms committee to help them. It's stunning. And I'm fascinated by this because I go into hospitals all the time and their systems are horrible. Their forms are horrible. Their materials are horrible. And they pay, hundreds of thousands of dollars, millions of dollars for the systems that they help us, log on and pay, and, send to us all the health education materials that are terrible. The number of materials that I get that are not tailored to my health condition is stunning. I was in a hospital 3 weeks ago to get a test done. I was supposed to get a fast test for just a urine sample for something. And I went there intentionally because it was supposed to be fast. And there was a big sign on the wall that said the fast test, and there was a kiosk. And so I went to the kiosk because the kiosk was going to be fast, and that's where they always send you. So I logged in the kiosk, and I was so proud of myself for doing what I was supposed to do. And then I waited for 45 minutes, and they kept calling the names of everybody around me. And so I went to the person at the desk, and I said, I haven't heard my name called. What happened? And she said, well, did you sign up at registration? I said, no, I went to the kiosk where it said to sign in. And she said, oh, well, everybody talks to the person at registration. And I said, well, but the registration desk actually says radiation registration, and I'm not going to radiation. And she said, but that's where everybody goes. Well, how would you know? So I go to that desk and I sign up and I wait 45 more minutes. But while I'm there, I said, I would love to talk to somebody in, patient services so that I could explain that this is confusing. And, I run a health communications company. I might be able to help you understand why this is confusing. Yeah. So after the big sigh, she gives me a phone number to call somebody that could help with that. And I call them and they say, oh, we're not really the people to call. We're going to give you the family liaison. So I call the family liaison and I get the number, and they tell me they're open, and the message open from 9 to 5 on Monday through Friday. This is at 2:00 on Friday. So I leave a message and I said, it's 2:00 on Friday. I understand you're open from 9 to 5. I hope somebody can call me back. It's been 3 weeks and nobody's called me back. At the family liaison number, which is the second number I called after I called the patient experience number, which is not the number to call. And this is to help me figure out how to navigate the system and make it more patient experience friendly, because the kiosk isn't clear and the signs aren't clear and you can't find your way around.
Right.
And there's nobody to talk to, right?
Yep.
So those are the systems you can't convince. For the other folks that you can convince, how do you turn them around? Often we show them the before and after. So very frequently I ask them for material and I show them what it would look like if we made it health literate. When we're doing our talks to providers, for partners, we often walk them through before and afters of things that we've been cleared to show. And I can show them the difference in what it's like. I've got tons of patient quotes where they talk to us about the difference between health literate accessible materials and materials that aren't. And people who want to get it due, we've all had that experience like the one I just described, where it's just so clear that the system isn't built for people. The system isn't built for us. Somebody created that signage that knew exactly where they were going. And the people in that system that is award-winning and big and making money hand over fist don't want to make it better. They don't want to make it clear, and they don't want to talk to anybody that can help. And I'm not going to change that.
Yeah.
They're not there to listen now.
Yeah.
So you change the people who want to change, right?
Yeah, absolutely. No, I couldn't agree more. And it's frustrating. And there's probably a lot of patients that are in your shoes like that, where they navigate it. They don't get the timely access that they need. And, it begs this question, right, of like,
well, that's when I tell the story, right?
Yeah.
So it's so funny. I sort of laughed that they didn't return my call in 3 weeks. So now every time I give a talk, I talk about them, and I have a picture of it that I show. And everybody says, do you want to name the system? And I said, I don't have to. I live in St. Louis, and you can see the sign on the wall, and you probably know who it is. And gosh, they still haven't called me back, and it's been 6 weeks. And everybody laughs.
Yeah.
Right?
It's real. It's real. Yeah.
It's a story that everybody experiences. Everybody gets it right then. We all experience that.
And this percolates at like the registration desk level, but even beyond that, like once the patient leaves the door of the facilities, I always tell this story too, and also a leading health system that I work with. We don't have to name them right now, but I always tell this story. We were working with a team for access, like a huge access initiative, improving access to care. And there was a physician organization. She was, or let's just call them they led up. They were like the top medical information officer physician in the whole organization, right? Like they're the leaders. And this story has stuck with me till this day. And it's that her mother, or a family member, let's say, of hers, had passed away, unfortunately, from breast cancer like the year before. And the health system was still sending that family member letters in the mail saying, like, hey, you're overdue for your mammogram, your next mammogram, like still. And what happened next was they finally rallied the marketing teams, like everyone behind it, and like put double down. But still, as you would imagine, there's still going to be pockets of areas where the system doesn't, cater to the patient. But there's so many stories of that. I mean, we can go on and on sharing stories that happened to my father recently.
Everybody has one.
Yeah.
Or 10, right? Everybody has so many of these. It's not hard to get an example.
Yeah.
And, what I say to people is, I'm saying this, I was trying to get a urine sample. I wasn't really sick. I don't have a serious health condition, and I have insurance, and I have resources, and I wasn't stressed, and I didn't take the day off work. Full-time
Right.
employee, it was not a big deal to me. What's
Yeah.
it like when you're one of those people who is underinsured, you are sick, you did have to take the day off work, and maybe you had to drag your kids with you, and you had to take a bus, and all the things that happen to folks who, have more resource challenges. And those people are out there, they're stressed, they're upset, they're trying to fight the system, and we can do better, right?
Yeah, absolutely. And we talked about stories of definitely what's broken, the challenges that we laid out. Are there any examples of like success stories that you've had with healthcare organization that really excites you? Like, hey, we came in, they were at this level that was clearly deficient, or there was a lot of room for improvement. And towards the end of the engagement with health literate materials and communication, they were able to improve, over time. Are there any stories that come to mind that have really excited you and your team?
Well, so not a healthcare organization, but one of the stories that I get most excited about is we do a lot of clinical trial work, and we got to reconceptualize the whole consent process with a global pharmaceutical company. And so we got to spend time focus group testing the initial informed consent. And we spent time with 100 people listening to what they thought the informed consent process was like. And we walked through what they loved, what they hated, how they experienced it. And as you might imagine, people are horrified by the standard global informed consent from a large pharmaceutical company. And we heard all the things that they hated, and we went away and we tried to fix them. And we got rid of the jargon, and we took all the bullets about the study, experience, and we turned those into tables, and we spent time making it as accessible as we possibly could. And then we came back and retested it. And we made a difference. Patients said things like, in time one, they said things like, I wouldn't join the study. I don't trust this company. They're trying to get one over on me. And in time two, they said something like, I don't know what some of this HIPAA language means. I don't know what some of this legal stuff is, but I'd do anything they ask me because I feel like they care. We didn't change any of the content. We changed the tone, and we changed the visual representation by taking out some of the words and making it visually appealing by turning it into charts. We took about 3 pages full of words and bullets about what they had to do and turned it into a chart, and we color-coded it. People said things like, we'd pull that out of the consent form and put it on the fridge so that we could make decisions about how we're going to get there, whether we're going to take snacks, whether our kid's going to be with babysitters, how we're going to get transportation, blah, blah, blah. But all those logistics that make people so worried, they were able to understand just because of those simple kinds of changes. Those are the kinds of things that people don't think they can do because informed consents are complicated and they're legal, and people don't want to touch the legal things. But if you dig in, and companies will, you can get through the legal process and create something that makes a big old difference for patients. And it changes the way they experience treatment. It changes the way they experience clinical research, and it changes how care is provided. So that makes me really excited that people are interested and willing to do those things that can take the fear out of the most complex parts of medicine. And that's fun. That's a lot of fun.
I love that story talk about real world impact with informed consent process with a huge global pharma company, and that sounds like it was impactful not just for their consent process, but for the actual patients. Like I think you just said like someone took it and put it on their fridge, the consent form. Like who would have done that with normal materials? Probably no one. You get materials and you kind of like leave it somewhere in a pile of papers, or you may not even look at it until the study date, when you have to go to it. So,
right. Or you just sign it because your doctor said so, and you don't know what you're doing. And, I was a research coordinator for many years, and I was a refusal converter. And so what that means is when somebody misses an appointment, at some point you have to go find them because you don't want to lose them to follow up. So I would get people when they missed an 18 or 24 month interview, And what tended to happen is people hadn't fully processed what they were supposed to do in the beginning. So they didn't even know they were supposed to come back. So I was finding people and they're like, oh, geez, I forgot that I was supposed to do it. And so when you have a clear consent to begin with, people understand what was supposed to happen. They know what they agreed to, and they're less likely to drop out along the way. It's easier to
Yeah.
keep them because you never lost them to begin with. And
Right.
those are the kinds of things that really matter. You don't want to lose people. You want to know what happened, and you want to be able to follow the experience all the way through and be able to measure the full, the full experience and be able to know what happened with the treatment and be able to make a difference. So it
Yeah.
matters.
And it's clear now that you've led some very impactful work with health organizations running clinical trials or health, because it includes both like traditional healthcare and also like health that like leading clinical trials and studies, which is an important part of the market. What is next for you guys at Health Literacy Media, and like how can interested partners or other health organizations explore working with you and your team?
Yeah. So, we're just continuing to do our work with partners. Everything we do is pointed toward helping our partners do a better job communicating with the folks that they work with. So, what's next for us is finding more interested people that want to do work like we do. We want to communicate more clearly with folks out there so they understand their healthcare. And if folks want to find us, they can find us online at healthliteracy.media. And we're on Twitter and all of the social media, healthliteracy.media, and we just love
Yeah.
to communicate with people. I'm Catina O'Leary, and I'm in all the regular places.
Yeah. Yeah. Spot on. Well, we'll make sure to include those links to your socials. And, I'm definitely going to keep tabs on the work you guys are doing. I think it's very important. It's a well understood need, but not as widely adopted as it should be. There's still a lot of work. And now with the advent of AI, I'd almost argue we need more of it, because there's going to be so much information flying left and right, and patients can like ask ChatGPT, ask other AI tools, and it's like at the end of the day, what matters is what the provider or the organization, if they're running a clinical trial, is communicating to them. Like
Right.
they need to be almost like adherent to that. Otherwise, it causes issues, like you're saying, when you're a research coordinator, someone like dropped an appointment or a follow up, right? Because that there was something in that communication or material that did not get either A, properly disseminated to them, or they or B, like it wasn't at all communicated, which could happen, or there's yeah. So definitely looking forward to keeping tabs, and it was a pleasure speaking to you today, Katina, and thanks for making some time and being a great guest on the podcast.
Thank you for having me.
Thank you.